Good day. I think, I don't know if my camera's fuzzy or just needs to get used. Yeah, that's better, I think. Okay. Does it look fuzzy to you guys? Zainab, how you doing? Madalena,
Hello, hello.
hi.
Can you add me as a panelist?
I'm sorry?
Can you add me as a panelist, or how
Okay.
can I
Who am I speaking
share
to?
my video?
Who am I speaking to?
It's Madalena.
Oh, okay.
Okay, that's perfect.
Yeah, there you go. Does my camera look fuzzy? It does, doesn't it? What's going on? These damn things.
Hello. Hello, I'm so sorry. My laptop didn't work, but now everything is okay. I hope everyone is okay. I'll share the events one more
I don't know
time.
what's going on with this camera. Let me try to plug it in.
I'm sorry. Have you asked me something? I didn't understand.
Oh, okay. All I needed to do was reboot it.
I'm sorry. Have you asked me something? Or
Okay, we're waiting. How you doing, Madalena?
hello, hello. I'm fine. Just
Okay.
finished a workshop we had on site at our university, and it was wonderful.
No excuses.
No,
Hey,
I'm
hey,
not making any
Madalena. Okay,
excuses.
we're waiting for the speaker, right?
Yes, I
Moy.
talked with him, and he said he would be here like 5 minutes ago.
Moy, he's not here yet.
Yeah,
Don't worry, he'll get here.
it's okay. Yeah, he'll be here.
Have you been texting with him or something? Have you been
Yes,
texting with him?
Yeah, he said he will be here. I just
Oh, okay, because we got 3 minutes. Some
texted
people, the veterans come at the last minute.
him.
The veterans will come in 1 or 2 minutes, boom. They do it and they get out because these guys are busy guys.
Yeah, and he said he just finished surgery, and he was quite tired, but I hope he's not too exhausted for us, because we are so excited for this this event, because it's a special month. We want to mark this with a lecture about the scoliosis, because it's an important subject, and yeah.
Yeah, so I'll introduce you and then you take over, right?
Sure.
It's one presentation.
That's perfect. Just
right?
one presentation,
Okay.
and after this we'll have a short Q&A session if there are any questions, and that's all.
Okay, so you're gonna, well, just run it. If you want to take questions during the webcast or after the web, whatever you guys want to do, whatever.
Yeah, we'll.
The only thing I ask is no dancing bears. Okay?
Okay, sure.
Not that you were thinking about doing it. But I don't know. I would kind of like to see this medium jazzed up a little bit, like TV. You know, like quick. Well, I mean, we're not that advanced to have quick video flat. You know what I mean? Like television. The good
Yes,
guys,
yes.
I know how to do it. And Michael Lawton, I tell you, if you watch his videos, have you watched some of his videos? It's called Base Camp. Michael Lawton's Base Camp. Excellent
Yeah.
production. I mean, Hollywood, because the Phoenix is not far from Hollywood. He's treated Hollywood stars. So I bet you that's the influence of production, movie production. If you watch his videos, you'll see. You won't see others like it.
I definitely will.
Yeah. Yeah, we don't hold tight to the time, whatever.
Yeah, I asked the speaker.
Zainab, are you in?
I think this.
You're in, right?
Mm,
Okay. Because I don't see in the panel, but I see in the waiting room.
Yeah, I think he entered the meeting, but he's not a panelist at the
Okay.
moment.
Did Tanmoy say he's on the way?
He said he entered the meeting. Let me check if he has the right link. But
Okay, we'll just wait. This
yeah,
happens a lot.
I'm so sorry. Mm,
He'll get here when he gets here. How's your club going?
Very well, very well.
Good.
We are quite busy in this weeks.
Yeah, you guys can get whatever speakers you want, really. No, really, a lot of people like to speak. They like to speak. And they don't mind going to, different places.
Hello,
Hello,
hello.
welcome.
Thank you.
You want to introduce yourself?
Hello.
Jacob? Do you know Jacob, Madalena?
Of course, but is the speaker here? I don't think he entered.
See, once we get advanced, we'll have a commercial. We'll do a commercial right now for like
Okay.
Medtronic. Really,
Yeah.
we're gonna try it. I'm trying to get those guys to do it. I've got one, I think, agency from China that will try it. I mean, you got nothing to lose. Here he is. Here's Tim. It's free, so why not? We'll get people to try it. Got to get more adapted, agile.
Okay.
Hi, do you see me now?
Hello, doctor. Yes.
Yeah,
I
hi,
can hear you,
welcome.
but-
Hi, Dr. Bennett, how are you?
Good, how are you?
Great.
Okay, the first thing, you're on two screens. You have to close all your programs other than Zoom. You've got two programs open.
Yes.
Is that-
No, that one I was not seeing you.
Yeah, just turn off everything beside your Zoom.
Yes. And then, but last one I was seeing my share screen option. Share screen option.
Yeah, take your time.
No,
See, I can hear myself twice.
You see me now?
Yes.
Do you see my? Do you see
Yeah.
my screen?
No.
Hello,
Yeah. No, I don't.
we're not,
And
we're not
I
seeing
hear
the
your
screen.
smartphone open. You need to turn it off. And you need to turn off all your screen other than Zoom.
All your screen.
Go away. You hear it
But
twice
you know
now.
why I'm not seeing? I'm familiar, but I don't see my share screen option. Like, you know, last one I see my share screen option.
Have you done a webinar? Have you done a Zoom before?
Yes, I did it with you before also.
Oh, okay. Okay,
But
listen.
why don't I see my share screen option? That's the thing.
Why don't you do this? Why don't you turn your computer off and start over again and come into the webcast?
Okay, let's do that.
You've got too much stuff open. Turn your computer off, okay? Turn it off. You've got too much open.
That's the reason.
Okay, turn it off.
I am.
Leave it completely, please.
Yes. Thank you, sir.
You're still there. You need to turn it off. You know, if you start from the start, then you only have one program open. As you can see, I can hear myself because he's got another screen open, probably a Zoom, but that'll be solved if you can turn the computer off. Okay, Tanmoy, can you turn the computer off, please?
Yes.
Turn it off, okay? That'll work. Let's see, he's not turning it off completely. He's turning it off halfway. Unfortunately, you can see his screen because he's probably just leaving the screen, not turning computer off. I think for everything to go back to default level, you got to kind of turn it off.
I think maybe if he would send me his presentation, because I have the screen share.
Okay, we could. That's good. That's a possible solution. Very good. He might be at a new computer. Sometimes you go to
Yeah.
a new computer, you're not used to. Okay, Tanmoy, you
Yes, yes.
still, you didn't turn your computer off. You need to turn your
I
computer
did
off.
actually. Let me try to see everything off. This is actually not letting me.
No, pull the plug out. Pull the plug out.
Uh,
Turn your
I think-
computer off
I think
completely.
it's. Oh. The sound is
Hello?
okay now. It's
Wait a minute. Is the
it
sound
doesn't
going?
have an
Are you there?
echo.
Can you hear me, Tanmoy? Hello?
Doctor, can you hear us? Is everything okay with the sound? Oh. We're so sorry about this.
That's okay. It's a tricky program sometimes,
Yeah.
especially when you're trying to solve it in front of other people. It's
Yeah, and especially when you're tired, everything
Yeah.
looks harder than it actually is. So
okay. He's
I hope everything will be okay. Doctor, can you hear us? Because the
I don't
microphone
even see him in the panel,
He
or
is. I see him in the panel.
yeah, I
but
can see it, but I can't see it on my my attendee list or panelist list. It's funny. I don't see him in either.
maybe it's a problem with the Zoom.
If he's got to reboot, he's got to totally reboot. If you can text him that, or tell him that he has to reboot. I'm not even recognizing him on the Zoom platform. Like I can see you, Madeline. I can see Edwin Potter. I can see Madeline. I can see you in two places actually.
Yeah, I sent the
Yeah, so
link
I
for
cannot
my
see.
colleagues.
Okay, now, okay. I think we're making progress because he's off the Zoom
Okay.
totally. Okay, now I hope just tell him to come back and just
Yeah.
come into the Zoom. Don't come into anything else. Just come into the Zoom, please. We'll solve this. Okay, he's back in. Okay, now.
But how do I share my
Okay.
screen?
Okay,
Yeah.
good. Okay, we cannot see you. Is your camera turned on? Tanmoy?
Yes.
Okay, you need to send the PowerPoint to Madalena.
Doctor, you can send me the presentation and
Can you send it to her, please?
I'll do the share screening.
Can you send me your email address, please?
Of course.
Because it looks like you don't have a good connection. Do you have your camera? Can you turn your camera on, Tanmoy? It's at the bottom of your Zoom screen on the left-hand side. Camera there.
I sent you
Well, once
the
again, he
email
has two
address.
programs open. Tanmoy, did you open another program?
No, I didn't actually. I don't know. The last one, I was actually pretty well in the system, but now I have like half the things I'm not seeing, to be honest.
Okay, okay, I tell you what, try the screen share. Can you try the screen share? You know how to do that?
You can just send me the presentation.
Did you get it yet, Madalena? You get the PowerPoint? No?
Not yet.
No. Yeah, you might be a strange computer. After surgery. Okay.
Doctor, did you send me the presentation? Or
It's actually uploading the.
oh,
Okay. That's okay, no hurry. Everybody understands bandwidth problems. Okay, is it still uploading, Tanmoy?
Yeah, almost did actually, and I think you got it now. Can you check?
Do you have Madalena? Did you get it yet?
let me just check it.
No?
Not yet.
Right now, Madalena, Popus, POPESCU, right? STUDEMFSCD.RO. Once more, check once more.
Do you want to try sharing the screen, Tanmoy?
Yes.
Go at the
If
bottom
she
of your
has got
screen, click on the share screen.
Yeah, I always see that option.
Do you hear me, Tanmoy? Do you hear me?
Clearly. Did you see that now?
No, I don't. You need to click on the screen share at the
Okay,
bottom.
I got a message.
Yes. Can you just share? Then I can just speak because we just want to come.
Can you see? Okay. Can you see me? Okay, let me see.
I see you very clearly.
Can you see me now?
And I see you, but
Okay,
I don't
me?
really
Okay.
see, I don't know, maybe some connection issues, but I don't really see my video option.
Okay.
Can you share the screen?
Yeah, you need to click on the share screen at the bottom. I don't know if you remember doing it before. Or you can email it to Madalena.
Did you get packet?
That's probably the best solution.
Yeah, I received it. I'm downloading it right now.
Go ahead, Madalena. Would you say?
I couldn't hear.
Okay, did you, Tanmoy, you need to send it to Madalena.
I did actually.
You did?
Do you see
I'm
Madalena?
downloading it.
Oh,
right
okay,
now.
Madalena, did you see it?
Yeah, I received the email, and I'm just trying to see.
Oh, okay, so you can share it? You're downloading it now?
Yeah, it's downloading. It's yeah, it just tells me that the site cannot be accessed.
You can't open the file?
Yeah. Oh God.
Yeah, I know they're tricky sometimes, PowerPoints.
Yeah, it just says that the site cannot be accessed. It's a link with the
Any issue?
presentation.
Can you text what you're saying? I can't understand you.
Okay, I'll let it in the chat. Maybe
In the chat, can you put it?
maybe you can. Let's see it. Can you try presentation?
Oh, I see. Okay, so that link you can't open it.
Yeah. It says that the site.
Okay, let me see if I can open it. Okay.
Yes, please.
Let's put a link. You gotta log in. Yeah, I see what you mean. Okay. We have to have the login information. Unfortunately.
Login information?
Yeah, to the Cleveland Clinic. I don't know if you want to give that or not.
Yeah, take it. I will.
Okay, you have to send it. Send it to Madalena.
I did it.
Okay, Madalena, he's giving. Under threat of death, you have to hold it secret.
Yeah. I kind of trust her.
Okay, well, wait till Madalena gets the password. We may be making progress.
Oh, okay. So I have to access the account. Please.
Okay, ask Tanway if you need more information. We got the link.
Okay, so on what site should I go?
It's up to you.
On that link, it just doesn't work. It doesn't require.
So that link doesn't take you inside the account.
No. It just says that it doesn't work. Just that.
Yeah. See here.
Can you send me the presentation on something else? Just upload it on.
Is the presentation on your hard drive? Tanmoy?
Presentation. That's the problem.
I know it's in the Cleveland Clinic account, but is it on your computer?
Just see.
Because if we can get it from your computer. Where are you at? Are you in the hospital?
That's the problem. Hospital, actually, I would have liked to be at home. The hospital is blocking my so many stuff. Is it wrong? Did you get this one?
No, Alex,
No, send to
yeah, she got the
Madalena.
code, but it didn't work, right,
No,
Madalena?
no, another one.
Password did not work. Is that correct, Madalena?
I couldn't understand.
What happened to the password?
It doesn't require me password. It just doesn't work. It
It
says that
doesn't work.
the site cannot be accessed at all. Like it's too private to be accessed at all.
Okay, let's try this another way. Tanmoy, is the presentation on your computer?
Can you use
Yes, and actually, to
WeTransfer?
be honest, the last time I was able to, I will probably.
Is it on your computer? Yes or no?
Yes, and I was able to, like, send it, like, share screen, and I was ready actually in that other one. You know what I mean?
No,
That
send
as
it.
I told that I was
Send
able
it. Do you have a Hotmail account? What kind of email do you have?
I have this, I have Gmail. I don't really have Hotmail.
Okay, if you can
This
send it,
desert,
you can send it to me. I'm gonna send you my email address. Okay?
that will be great.
Yeah. Let me send you email address and let's be methodical about this. Okay, I'm in the chat. Can you see the chat? Can you see that? I just said chat.
Yes.
Okay, you see that? I'm gonna give you my email address. Okay, there's you see my email address?
Oh,
Yes,
that's
I
you.
can see
Okay.
You see my email address?
Yes, sir.
It's in chat, in the chat.
Yes, I see. I see.
Okay, so can you try to send it on that email? The link, Marlena, the link is from a private account, which needs a password, right? We're not giving up, folks. Right, Madalena?
No, not yet.
No,
Waiting
not
for
yet.
this meeting.
Did you see me?
Okay. Let me see if I got it in your email. Danmo, okay, I received it. Okay. Let me see if I can open it. Download package. I think we may have. Okay, I need a username and a password.
I sent it to you.
Okay.
I don't know whether everybody
You
sees.
need to send it to me. You can put it in the
In the
chat.
chat itself.
Oh, there you go. Okay, I got it. Okay, we're moving forward, I think.
This is the first time I'm not able to share my screen, and this is pretty new to me. I don't even see the option. Like I'm seeing it, and then I don't see it. That's it. Simple. Maybe some connection, maybe something.
I think there are some problems with it because my colleagues next to me, and they also have some problems. I had problems connecting.
I was logged in, if you remember, in the other one, and then that there I shared my screen, and this one I don't even see my share screen. I don't see anything. I was like, okay, what is it?
Yeah, I don't know what's happening. I'm sorry about that.
But sir, do you see it now? Means like, can you download it?
I'm still trying to get into the account now.
But it's open, right?
Okay, it's opening now. Yeah, yeah.
Perfect.
Okay, it's launching. Something's happening.
Okay, finger
Install
crossed.
connect. I have to install a couple of programs. Just install. Is it? Oh, I see. I see the presentations. There's a DBS case. PCAD. Got it?
No.
DBS. Well, actually, I'm going to share the screen and show you.
Yeah, that's
How's
good.
this now, Louina? Is this fun?
No.
Okay, there we go. You see what I see, right?
Yeah, so we see the screen.
Okay,
No. You have to
Which one
put
is
the sent one. Go to the sent option, the received option.
go to the what? I can't hear you. Go to the what?
I think the next page.
Oh, okay.
Sent.
No?
Sent. Off screen, you see received.
Oh, on pending. I think.
Oh, is he sending one now?
Part of the screen. There is new package received, sent, and pending.
Okay, can you text what you're saying? I can't hear the word you're saying.
Click the sent option. You're not able to open the sent option.
Which one should we open?
On the top.
CCAD?
Do you see like first is like then a new package received sent and
I can't understand you.
top of in the blue line. Do you new package
Back to normal view?
No, even do you see a send button on the top?
What, you see what at the top?
Send.
That-
Yeah, there. On
Okay, oh, okay. Maybe this is,
Yes.
okay,
That's
I
the
think,
one.
okay,
Oh,
you
yeah,
may
this-
got it.
Yes.
Okay, we may have it.
That's download.
Yeah, give me a second. I think it's downloaded. Overview, PowerPoint, right? I think we got it.
Okay. So let's start quickly.
Okay, hold on. Now we gotta work on your audio. But let's get the video working first.
Run.
Okay, done.
maybe if we move ourselves, we better.
Okay, I think I may got it. Okay, yeah, success. Is this the one? Well, I don't know if that's the right one. Scoliosis, that's not it. Yeah,
I don't think
damn.
this is the one.
Oh, okay, there we go. Hold on. Think I got it. Okay, you can see it, right?
Yes, yes, we can see it.
Yes, all right. Okay. Okay, now let's work on your audio.
Yes. So it's fine.
Do you have a smartphone?
Yes.
Okay, I want you to go to your smartphone and come into Zoom with your smartphone. Get off this and enter the webcast through your smartphone. Turn off your computer.
So,
Okay.
doctor, connect the phone.
You need to leave this and come in to the webcast with your smartphone.
Okay, let me do that.
You know, leave this webcast, please. The audio is just not working on this computer. Lift it up.
Okay, I switch off that one. And this one.
Okay, we can hear you now. Okay, I don't know what happened. Can you talk now? Can you talk now, Tammy? Oh, okay. Now he's finally leaving. Well, I asked him 10 times. You can see the presentation, right?
Yes, everything is okay.
Yeah, we just need
Presentation.
an audio, and most times smartphones, the audio is fine. You don't need the video, you just
Yeah.
talk.
Yeah, so can you just move the slides so we can see that?
Yeah, I
everything
can move
is
them on
okay?
his command.
Yeah, just press to see the. Okay, it's
Yeah, I can move them, no problem.
It's perfectly
Gonna
fine.
get a decent.
Yeah, sorry about this. And until everything is okay with our speaker, I would like to address some words for our participants who are very. Uh, I admire their perseverance that they didn't leave us, and I want to thank them for this, because sometimes it can be hard with the Zoom and the devices that we use. And thank you for understanding this and not leaving the meeting, because we have a very special occasion for this meeting. June is Scoliosis Awareness Month, and we wanted to mark this event with a lecture about scoliosis, about its management, which is very important to be aware of, to know it, and respect everything that is about this management. Okay, so I didn't present myself. My name is Madalina. I'm a fourth year medical student at Caro Davila University of Medicine and Pharmacy in Bucharest. I have the pleasure to be the president of an amazing student society, which is Walter Idendi Neurosurgical Club Romania. Our activity is about neurosurgery, but not only neurosurgery, but also neurology, neuroscience, and we are very passionate about the brain, the spine, and everything that is connected to the nervous system. We have activities like workshops, hands-on workshops. We have conferences like this one, but also we have an educational part with student sessions in which we, as students, present to other students, and we try to get some public speaking characteristics, and to learn and teach others through our learning. And this is our club. We collaborate with a lot of hospitals. We have um, many groups, little groups in every university, in most of the universities in our country, and we all collaborate and have amazing events. So I don't think the speaker. Okay, please again the meeting.
Yes. No, first of all, thank you, Madalena. Thank you, Dr. Bennett. This is an excellent opportunity for me. And we
Thank you so
lost quite a
much.
bit of time. I know
Thank
that
you.
everybody, and I really, really sincerely appreciate who are still there, who have not left us. I will try to be as short as possible because we lost quite a bit of time. So, yes, as Dr. Madalena said, that this is June is Scoliosis Awareness Month. I will talk few things about scoliosis, and then we can go for the next slide, please. Okay, to overview, scoliosis can happen at the younger age group as well as adult age group. The classifications and are different, and so this is what I'm going to say today: a bit of pediatric, a bit of adult, and whether the cervical deformities are different, and a lot of my surgical cases. Next slide, please. So pediatric scoliosis, next slide, can be divided in three, like age group wise, like when they're less than 3 age group, infantile, and the juveniles are the 4 to 9 age group, and adolescents are when they are 10 and higher. The causes are different, and the managements are also different. And let's go to the most common of out of three are the adolescent scoliosis. Adolescence means like in when you are seeing at when you're starting to grow, you see that a little bit of curve is going to be increasing. Most of the time these adolescent curves are idiopathic, and it is a kind of diagnosis of exclusion, but most of the scoliosis cases are in this category. Next slide, please. So let's talk about adolescent scoliosis quite a little bit more. Next slide, please. So as I said, that this is a diagnosis of exclusion when all other things we are excluding, for example, neuromuscular or a congenital or a syndromic cause, syndromic, for example, Marfan syndrome or Ehlers-Danlos syndrome, then we name that as adolescent idiopathic scoliosis, mostly a 10 to 18 age group. By definition, in a coronal curvature, when we see it is more than 10 degree, we tell it is a scoliosis, but all of them are not really symptomatic, or all of them not really need any surgical correction or anything. Most of the time, the less than 10 degrees are like the left side is the convexity is towards the left side, and right side curves are most of the time, many a times are pathological. Next slide, please. This is how we examine the patients. Like you see, when they are standing from back, you can see that there is shoulders are not at the same level. You can see from the front also that shoulders are not in the same level. When you are seeing from the back, you can see that one side scapula is up, and when they bend forward, you can see there is the upper, that scapula is more getting more prominent. We use this center picture, we use this scoliometer to see how they are like rotated, because in x-rays most of the time you see anterior, posterior and lateral, so two-dimensional, but when you're examining the patient, you actually can see a three-dimensional picture. And the bottom left side, you can see in this patient, there is a left side, there is a extra skin fold, and the right side it's more straight. So this is sometimes concerns the patient. And you can see the hips are many a times tilted. And I have not shown the foot, but many a times they have flat foot, or one leg is a little bit longer, kind of leg length discrepancy. That's how we turn them. When they lie, these patients, sometimes their curves are either hyperlordosis or less lordosis, hyperkyphosis or less kyphosis. So some part of their back is not actually touching the bed, and the patient gets like bed becomes tired because of that, and they are not getting enough rest because their body is not really touching the bed. And many of these patients will come to your office by saying that when they wake up, they feel very stiff, and then as the day progresses they feel better, and by the end of the day they're pretty tired, because our muscles, paraspinal muscles, are trying to make them straight all the time during the activity, and by the end of the day these muscles are getting pretty tired, and the patient is feeling tired and more pain. Next slide, please. Next slide, please. So there are multiple classifications, and the classification is extremely complex. So better we don't go into each of them. The Lenki classification is the one which is more which came as the modification of the first classification, and it is more reproducible, and the most of the clinician they could follow this classification, and this is important for a treatment perspective as a surgical perspective. So this is the one all over the world, the surgeons who deal with scoliosis we follow. Again, this is a pretty complex one. I will try next few slides a little bit. Next slide, please. So this classification came in 2001. This has 6 types, curve 1 to 6, and something called a sagittal modifier and a lumbar modifier. What are they? Next slide, please. So what is a structural curve? So any curve which is more than 25 degree in the coronal, and we do a AP X-ray, a lateral X-ray, a side bending X-ray. So right side bending and left side bending X-rays. So in the X-rays, in the bending X-ray, many a times some curve gets straightened up. When these curves are still exist after the side bend, then we tell them as a structural. The one which has the largest carb is major, and the other carbs are called minor. But minor carbs also can be problematic and can be more than 25 degree. Therefore, they can be also a structural carb. So what is in the thoracic, we tell proximal thoracic T2 to T5 level, and below that we tell this is a distal thoracic carb. Thoracolumbar is from T12 to L1. Here important is the disc up to T1, T12 disc is lower thoracic. Thoracolumbar is a very small portion, T12 body to L1. Again, from L1 to disc to L4 is called lumbar curve. So generally, pediatric curves are kind of close, stops at L4. Many, very less of the time they go to L5. So when we do surgery, we try to preserve. Our main target is to straighten the curve and also to preserve some segment to preserve the mobility. So we almost never fuse L4-5 or L5-S1 when we are trying to do the surgery. And many a times we are able to save L3-4 level as well. Next card, please. So this is how X-rays we do. You can see AP X-ray, a lateral X-ray, and then patient is bending. And this is what we are seeing, that the four types, thoracic, lumbar, and thoracolumbar. What is a coronal modifier? We try to see and how this is how we measure the Cobb's angle. The upper part of the curve, upper end plate, and lower part of the curve is the lower end plate of the lower body, which has the maximal curve. That's how we calculate the Cobb's angle. Next slide, please. And again, this is pretty complex. I'm not going into details of that because you will anyway not remember. I will try to say just say the outlines, and these all things you can get from internet or you can get from me whenever you want. Next slide. So this is how we measure the coronal modifier. So we draw a line from middle of the sacrum and try to see where it is passing through in the lumbar apex. The first 1A, you can see this is going through in between the blue one. You can see line is going in between two pedicles. So this is 1A. When it is going from the one end of the pedicle at the edge, then it is 1B. And when the line is going through outside the pedicle, then we are telling that it is 1C. Next slide. And this is how we measure the sagittal modifier. Again, we are drawing a line, Cobb's angle, from the top and the bottom, and we are seeing whether this is 10 degree and whether it is less than 10 degree, whether it is more than 40 degree, and something in between. So if it is in between, this is normal. So 10 to 40 degree is normal. Anything less than 10 or more than 40 is not really normal. So when we do surgery, we try to bring it in between 10 to 40. We don't want a hyperkyphosis in our correction. We also don't want a hyperlordosis in our correction. So we want to bring it kind of a middle of it. Next slide, please. So this is the whole classification. In case you are interested or you want to see, the best thing is to carry this as a card and try to see which card where it is matching, because otherwise it's pretty difficult. So you can see proximal thoracic, main thoracic, thoracolumbar or lumbar, and then which one has a structural curve, which one has a non-structural curve. Based on that, we have 6 types, and you can see some examples in the bottom. Next slide, please. So when we do recommend surgery, so most of the time we see what is the curve. Some surgeons prefer, most of the surgeons worldwide prefer to wait till 45 degree, or somebody whose curve, so it is general natural history is the curve worsens by 1 to 2 degree per year. If a carb is worsening by more than 5 degree per year, or say like 10 degree in over 2 years, then you know this carb is going to progress. So then it becomes an indication of surgery. Otherwise, generally we wait for 45 degrees, or rarely patient develops like a weakness or a severe radicular symptoms, but all these patients have pain, chronic pain. So pain only is not really an indication for surgery. But when they are like combined with the other factors, then we consider surgery. Rarely they can cause a one lobe of the lung collapse. Most of the time right side middle lobe collapse. Sometimes it can cause a, it becomes like a constriction on the heart. This all becomes a emergency, and then we need to do either a heart a release surgery in front of the heart, or a scoliosis correction surgery when the lung is considered. But most of the patients, they don't really need surgery. And generally the brace is important when they are actually transitioning. So up to 14 15 age group, we recommend at that time the carb is really can be modified, and it's not really fixed, it's very much non-fixed. So with breast they can be helped, and the breast needs to be changed over 6 months or 3 months to see that whether the carb is getting better. To adjust, we have to adjust the breast. But after this, brace doesn't really work, and brace is not going to give you improvement. And at the same time, brace is not really easy to wear for 24 hours. So we see, like we try to see whether daytime only or nighttime only, or how we can adjust the brace into fit into somebody's schedule. Next slide, please. So how we select, like, what should be my upper level of surgery, what should be my lower level of surgery? So next few slides are kind of, I would have gone through because if it I had more time, but I would like to say most of the time our principles are, the upper level is based on right side shoulder is up or left side shoulder is up. If right side or it is central, there is not much of shoulder discrepancy. So that's how we decide whether we want to go up to T2 or T3 or T4. Most of the time T3 is kind of our upper level, and our lower level is where the lumbar curve is ending. That is the most like easy way to remember. Many times the surgeon do not really follow all these guidelines. They try to see where the curve is ending, where the curve is ending on the top or curve in the ending in the bottom. And all of them, we always try to see where is the shoulder, and then we try to rotate them so that the scapula do not become prominent. Next few slides, you can go for the next one. So this is how in the type 1. So this is where the left one is like where T3, we are going up to T3 where shoulder is balanced. And then next one, so here we generally scoliosis surgeon, we see right side as right, left is left. So where the right is higher, then we are stopping at T4 or T5. When the left is higher, we're going up to T2. Okay. And 1A and 1B are important to decide what is our lower level. So where the carb is ending, so you can see based on where the carb is ending, the yellow line marks the lower end of the fusion. So you can go through the next few slides. So this is type 1, type 2, next slide, type 3, and next slide, next slide, next slide, please. So these are like in the type 1 to type 6, we kind of try to make a guideline what will be the upper level, what will be the lower level. Next slide, please. So this is one of my patients. She's a 15-year-old girl, and over last 2 years she was kind of having significant progression. You can see that her shoulders are different level. When she's bending forward, this is the test we do all the time. You can see that her right scapula is becoming very prominent. You can see when she's standing upright, she has in the left side, she has a extra skin crease on the left side, and the right side is pretty flat. Her hips are also not in balance, and when she's bending from the front and when she's bending forward, you can see that her is becoming little bit of kyphotic, and it's becoming like a hump in her back. So of course she's a young girl, she doesn't like this or any of this, right? So next slide, please. So when we do the x-ray, this is left side was her pre-op x-ray, and right side is the post-op x-ray. You can see that we could make a like lower L2 3 like L3 4 5 we could preserve, and we stopped at L2 to keep, because in thoracic area when we fuse, because of rib, we are not really losing much of mobility. But in lumbar level, the maximum mobility is L4, 5, L5, S1, but upper one also have some mobility. So we try, if we can stop at L2, that will be probably best. L3 will be our next target. If we hardly try to go to L4 or L5. So at least two or three joints are preserved, so that the mobility is preserved. So this patient will hardly lose maybe 5 to 10 degree of mobility. So only thing we tell our patients, that only thing she won't be able to do, so before surgery, if she is able to tie her shoelace in standing position, they won't be able to do it. They have to sit down, put one leg over other, and tie their shoelace. It will not be possible to standing position tying shoelace, but otherwise with the exercise, with making the muscles, they can be pretty flexible. Many of our patients go for uh, horse riding or skydiving, going for swimming, or everything is possible. We don't really any restriction after the surgery, or when they go for pregnancy or childbirth, means like there's not much of issues in those normal activities. You can see in the lateral x-ray, this is what is very important. Though the AP X-ray is something we try to show our patients, the lateral X-ray is the one which is important for the surgeons, where we are trying to maintain the sagittal balance. We are not making them very kyphotic or very lordotic, because that will cause a long-term problem and a cause of a severe chronic pain. Next slide, please. So this particular patient, we published this in operative neurosurgery. Next one is another boy. You can see the boy also, same thing. You can see the scapular prominence, you can see how the spine is bent, how there is a skin crease. And if you see the lower side, left lower bottom, the x-ray, so this is the x-ray. First two are the x-ray when he was 12, and the second, like photo number 3 and 4, this is when he is 17. You can see how much progression, how much the curve has progressed over 5 years. You can see that patient, the last foot x-ray, if you see, when he's lying in the bed, his back is not really touching the bed. And so we did the surgery. You can see after the surgery, the skins are, the scapulas are pretty flat, looks like they're at the same level, and we got a good correction, and we could maintain the sagittal balance also. Next slide, please. So this both the patients, those videos, surgical videos are published. First one was in operative neurosurgery, second was in neurosurgery focus. So neuromuscular scoliosis is like scoliosis in say osteogenesis imperfecta, cerebral palsy. And this is where your muscles, your pelvic muscles are weak. So these patients are in bed bound, they are not able to really stand there. So our target is to make them at least sit, they can, so that they can sit down, and their care can be taken, like they can sometimes stand with walker or with support. But even when the patient are able to sit, that is kind of a success, because many of these patients are coming as completely, their hip, it's like they're so weak, they're mostly in the bed. Next slide, please. So these are the causes of neuromuscular deformity. Next slide. You can see one curve, this patient, the front x-ray and the lateral x-ray. You can see in the lumbar region, if you see that the lumbar spine is hyperlordotic and the thoracic spine is very straight. Patient already had a cervical spine surgery. Go to next slide, please. And we did a surgery, we kind of could manage to make it straight. Next slide, please. This is the top part, and next slide. This is kind of the sagittal x-rays at the top and the bottom, and we could kind of correct the curve, and this patient was able to like ambulate with support. Next patient. Next slide. So these photos are not my photos, not my surgery photos. So when we are doing these cases, many a time you will see especially as some surgeons, if you don't do a MRI scan, you can miss all these things. Though adolescent idiopathic scoliosis is the most common cause in this age group, you really need a whole spine MRI, because sometimes there may be a tumor, like in this case, like an intramedullary tumor. And next slide, there may be something like a syrinx or a craniovertebral junction anomaly. Next slide. So many a times surgeons see the x-ray, they correct the scoliosis, but they don't really treat the cause. And then after some time, the instrument is going to fail, and something else is happening. Then you do a MRI, and you are like, oh my God, this is there inside. So we needed to treat that one first before we correct the carb. And then in the presence of instrumentation, that becomes very difficult. Next slide. So these are two photos I took from internet. This is the adult scoliosis. Adult scoliosis can be kind of two types. One is like untreated adolescent scoliosis, which in when they were like from 20 to like age 50, they were kind of stable, and with little bit of degeneration, they start to worsen and the cards looks bad. The first photo which was there in my title slide, this is kind of adult scoliosis, which was exactly like this. So he had carb all his age 50 years of age. Then kind of that carb got little worse. Then we had to correct it. The other one is like in 60s, 70s, where because of the degeneration, this is becoming very scoliotic and kyphotic, or sometimes only scoliotic, sometimes kyphotic. Many of the old people, you will see they are bending forward and with a hump in the back. So that is kind of a kyphosis. If you do X-ray, AP and lateral, you will see actually they have scoliosis also. Most of this scoliosis, the carb is more at the lumbar region, and the kyphosis is more in the thoracic region. Let's go to next slide. So at our worldwide, the population is aging. Many of the patients, as the life expectancy has gone high, and many people are aging. So this particular population is coming into consideration. Earlier, maybe if the patient is becoming 60, you tell, okay, I'm not going for surgery. Risk is very high. Now you are having so many patients of 80s, 90s. So what are you going to say? Like 60 to 90, don't do anything? Not really possible. So people started doing, trying to one level surgery, two level surgery. It's not really working. Then the surgeons went for, I mean, say in last 10 years or 20 years, as the engineering has progressed, like our screws are much better than before. The surgeons have become more adventurous, and we kind of try to do a very long segment fusion. And next few slides will be like that. Next slide, please. So this is the example of what all things can happen. It can happen in the cervical area. You can see that it's not really one level or two level. There are multiple level deformity. And now what do? You do a one level ACDF. Patient will come back with the persist symptoms of persisting with the two level. So then you are in a dilemma. Like in our when we were residents, we were taught if you do three level or four level ACDF, you are basically failed. You fail the exam. If you tell that you're going to do the four level ACDF, that's it. So now, actually, many of the surgeons are doing that. You will see here and there, and you can see the lower photos. Then all the spine is all the levels are very degenerated, and then the last one, you can see the spine is very kyphotic. This is probably like our grandmothers or grandfathers. You see, they are bending forward, and with the help of a stick and their hump, they have a big hump. Next slide, please. So we made kind of the wild range of again, I'm not going into this will be very very extensive, but let's go to the next one, please. Next slide. Yeah. So again, the one before. So we want to know who worsens. So over no, not this one, the one before.
Is that okay?
The next one, please. Yeah. So we want to know who worsens. So we found some criteria that who worsens, and we always try to see in the X-ray what is the pelvic incidence, what is pelvic tilt, and what is sacral slope. So these are the three factors we always see. We see other measurements, but these are the main factors how we decide that how we are going to fix. Next slide. So these are the other factors. You see that you draw a line from the C7 vertical line. You try to see what is the distance between posterior superior part of the sacrum upper border and the when you are drawing a plumb line from C7, how much it is forward of that or backward of that. That is in the lateral X-ray. In AP X-ray, you are drawing a line from C7 and you are drawing a line from middle of the sacrum, and you are seeing that how much is the distance between these two, and then you know what is the curve and how much you have to correct. So a sagittal axis and like a vertical axis, coronal axis. Next slide. So this is the realignment goal in these surgeries. We tell all the patients are actually in a cone. So if this cone is the actually we tell cone of economy, means this is how the patient should stand. So anytime the patient is going out of this cone, their body is actually trying to bring it back. So their muscles are becoming like very painful, very weak. So whether so you know they are in unstable. So your surgical goal is to bring the patient back to this cone. Next slide. So adult classification is not as much widely accepted as the Lenke's classification for adolescent. This is also based on multiple classifications. So SRS is the Scoliosis Research Society. They have come up with a classification which is a mixture of all the classifications, including Lenke's classification. Kind of this is again a long one, complex one, a kind of a working one, though many of the surgeons don't really follow it. Next slide. So surgical approach can be from any side. Like you can most of the surgeons prefer to do from posterior, but some surgeons do anterior lumbar interbody fusion. Lateral surgeries are like X-leaf or O-leaf, and many of the time deformity actually have to do a combined surgery, a mixture of anterior. A posterior will be one part of it, or you have to choose between anterior and lateral. Surgery can be done minimally invasive way or a open surgical way, the classical way, or a combination. All of these surgeries we have to do intraoperative neuromonitoring. Without neuromonitoring, no scoliosis surgery. Next slide, please. So this is again a working classification. You can see this is a flow chart of how where the MIS surgery can be done, like minimally invasive surgery, where actually MIS surgery is very risky and you have to go for an open surgery with osteotomy. Next slide. So other factor for adults are like to think about the osteoporosis, that whenever you are treating, you can't really put the screws if the patient's bones are weak, so it is going to break. So we have to know about these medicines and the old medicines. There are new medicines, something called Prolia and Forteo. These are two new medicines that are better than the earlier used medicines, and with less with the bisphosphonate, which we all read in med school. Probably you guys are reading about the new medicines. Bisphosphonate was our time the medicine of choice, but has multiple risk. So now this Prolia and Forteo, these are pretty available in United States and most of part of the world, pretty much practiced by the endocrinologists with lesser side effects and good bone remodeling. So we generally try to start this medicine about 6 months, 3 to 6 months before surgery, continue so that our instrument do not break. If a patient is in osteoporosis, we don't really jump into doing a surgery. Next slide, please. And we also have modified our surgical technique to counteract osteoporosis. So the screw has become better with to address this, and the surgical technique has also got better. And we have used multiple methods, techniques, so that the next level where we stopped fusion do not go into degeneration and we have to extend the surgery. Next slide. This is one of, and that then there's other techniques. So this is one lady, and she's 71, and this is, you can see that what I told, like they have a AP X-ray showing a scoliosis and the lateral X-ray showing a kyphosis. So this patient was very frail. You can see the next slide, please. So you can see she's very frail, and so we were very scared, to be honest, that whether she will make it. We tried to not do surgery. We kind of tried to avoid her, and then she was keep on coming back, and then we kind of 1 year we are waiting, and then finally, okay, let's go for surgery. So we thought, she's her weight is not much. She had multiple comorbidities. She is not really fit for a long surgery anesthesia way. We thought we will do in 2 stage. You can go to next slide. First day we did some osteotomies. Osteotomies there are multiple types. I will put one slide for that, but it is pretty complex for you guys, where we remove part of bone, starting from only little bit of facet, or removing the whole spinal, like a vertebral body from back. So whole surgery was done from the back. We thought like from anterior, from lateral, that will be too much for her. We will do only from the back. So first day we kind of released and did some bone work. You can go next one. You can see like we did kind of half work. We would put half screws, one side rod, and we release the bones. Next slide. And then it was like a long one. So we upper level was thoracic 5, lower level is sacrum. And most when this type of carve is there, we always have to put a iliac screw or a S2 LR screw. So you have to basically include pelvis into the construction. Next slide. Then you can see we could make her completely straight. And as we did in 2 stage, she could actually tolerate the procedure very well. She went to ICU like electively, but surgery time was very low. Both the time, like by 2 o'clock, we were done, and she had to stay ICU for 2 days or so, and then she came back. She was actually did very good recovery. Next slide. So other thing is, I'm talking about only whether only to do like long segment, like from thoracic 4 or thoracic 10 to sacrum. It's not really always true. You have to understand what exactly patient is having. Many a time it is possible that they may have a big carb on the top, but they are not really symptomatic for that. Their symptoms are at the lower end of the carb, which is like a L4 to sacrum region, which is actually secondary to the upper carb, but they probably have only one side radiculopathy because of a L5S1 disc. So you do a nerve conduction study, you see that upper level there is nothing. There is only one L5S1 radical. Only one radical is involved because there is little bit of disc and foramen is compressed. So then you don't do any screws. Don't do any screws. You first address this one. Maybe you just do a little bit of foraminotomy, little bit of discectomy, and patient is doing great. So you can avoid the whole this big surgery, which can be problematic for the patient. So this is something called a fractional carb. So many surgeons always try to address this one first before going to. If this fails, then only to go for a long segment. Don't really jump into a long segment surgery. Next slide, please. So how cervical surgery is different from a lumbar surgery? Uh, Next slide, please. So cervical deformity was even more newer, like I will say in last 10 years, people are discussing more. We were used to fix the thoracic and lumbar part. We hardly address that, there is one level ACDF and patient is complaining pain multiple times coming back to office. But we are like, okay, one level ACDF is done. We're not going to do much more than that. But sometimes you can see the patient's like neck is always like, you can see maybe the chin is almost touching the neck, or chin is like looking up, and they are not really comfortable. Then there are multiple parameters. We try to see all these angles, the T1 slope, and what is the outlet angle, what is the inlet angle, and how much is neck is tilted. And then we kind of try to find out which all angles are important and which all are not really that much, and which all things we need to take care when we do the surgery for this. Next slide. So these are some of our previous surgeries. You can see how when the first one, how the neck is kind of bending forward. Whenever the neck is like his patient is bending forward, you can see how the spine is going into not really a good posture. When they're straight, multiple levels are degenerated. You see the MRI, multiple level, there is compression. And we had to do front and back surgery to give a very good curve. Next slide. Again, similar picture. The surgery was previously done, but patient has compression in the upper level a little bit, but mostly in the lower level where the next level of the previous instrumentation. Then we had to do front and back to give a very good picture. Next slide. So again, one of the same thing. The first, this patient had like came to us that first two level was fused, and in the second surgery, C3 to C6 was fused. In between, there was no rod. You can see the AP X-ray that two rods are not in the same level. And then it was like the top was problem, the in between level was problem. Patient was feeling the two rods are touching each other and kind of a sounds coming off. So we had to kind of fix her from front and back. Next slide, please. So osteotomies, as I was saying, there are multiple articles. This is one of my favorite article where grade 1 to grade 6 are described based on how much bone and disc we are removing. Type 1 to type 6 is very complex. You just have to little bit know as a med student that these are like the ways to correct the carb. And next slide, please. The complications are pretty high for adult scoliosis. The adolescent scoliosis is not that much because most of the children, they tolerate the surgery pretty well. But for the adults, even in the best hands, the surgery, like when they talk in their own discussion, the complication is as high as 40%. You can see age wise 25 to 44, when they're going from 45 to 64 or more than 65, the complication rates go high and higher. Next slide. So you will, if you go to any conference, you will hear these two words. What is adjacent segment disease? So one part of the spine is now fused and the next part is not fused. In that junction, so the top of the fusion level, that junction, the disc and bones are in stress, and there some changes can happen, which we tell a proximal junctional kyphosis. And the second one, distally, we tell is a distal junctional kyphosis. This is one of our patient. You can see the lower one. If you see, this is for a young patient. You can see that how the head is almost hitting the back of the spine, and kind of you can see the top part of the screws. This is a previous surgery, and top part of the screw is almost touching the head. So the skin over that area is completely eroded and completely unstretched. So we had to re-explore that part, and we had to go above. So this was previously stopped at T4. So we had to go above and put some screws and make it straight. We released the bone. You can see that the last one, the spines are in much made better like curve in compared to the left side. Next slide, please. Again, same thing. You can see that here we had to actually do more. So you can see how much it is at the top of the curve, how much it has bent forward. And that again, the head is touching the back. Again, we had to do some release, do some osteotomies, and we could make it straight. So again, these two patients, one patient we did only facet resection, one patient, the second patient we had to remove the whole body. You can see there is a cage there in between two screws. And this particular one also got published in and Focus, and Neurosurgery Focus. Next slide, please. So and second thing is pseudoarthrosis. Pseudoarthrosis is when we are putting the screws, the purpose of that is to attain a fusion. And if this fusion doesn't happen, or the carb is progressing, despite you did all this, we tell that actually it has not fused and the carb is progression. So it's a failure of surgery. So this is the second term which you will listen more and more when you go to your neurosurgery training. Next slide, please. Next slide. Okay, so this is Dr. Ed Benzel, whom you all know. This is his kind of favorite dialogue when I happened to be in Cleveland, Ohio, and this is what he will use. So every surgery is a deformity surgery. Either you are treating it, or you are during surgery, you are trying to prevent it, or you are actually causing it by doing wrong surgery. Next level, next click, please. So complications are high even in the hand of masters, but results are rewarding too, as you saw in previous slides, right? Next slide, next please. So stay careful in every step. So many of the surgeries, adolescent surgery, even in the best hands, it takes about 6 hours, and the adult ones are even more longer, sometimes 12 hours. So it is sometimes difficult to stay focused. Most of the time we do the surgeries as two surgeon principle to be more watchful, because one surgeon is getting maybe tired, or putting and two surgeon can speed up the procedure. Two surgeon can put the screws from two sides and can correct each other, so that it becomes very helpful. Next slide. So all the patients need to be seen as a different patient and from each other. Some patients may need no screws at all. You address the fractional curve. Some patients need a small segment. Some patient may need a long segment screws. Next slide. And you have to treat the modifiable factor. You have to tell them to stop smoking. You have to tell them take medicine for their osteoporosis. You have to tell them to go to gym and lose weight, obesity. So all these are very important factors. You do a surgery for a very obese and smoker, surgery is going to fail, no matter how good surgeon you are. Next slide. And you need a very good team who are doing this regularly, two surgeons with the intraoperative monitoring, with use of a good radiographer who is coming to help you during the surgery using the C arm or the O arm, whatever method you are using. And of course the anesthetist, because when you are doing the screws, you want, or dissecting, you want the BP to be lower side. When you're correcting it, because spinal cord is in stress, you need the BP to be on higher side. Throughout the surgery, you are maintaining how much is the blood loss. You may use the cell saver, you may use thromboelastogram technique. So all these are very important. And also many of the patients go to ICU. So you need all these people, and surgery is actually the teamwork, is never the only surgeon. Next slide. So this is the top left is my mentor who has taught me all this, and many of the few slides are my own surgeries, few are my mentor's surgery which I assisted him. And I belong from India. The top one is my first institute, neurosurgery, and then I went to US, the LSU, and then you can see Cleveland Clinic, and then I was in Mayo Clinic, and now I'm in Cleveland, Abu Dhabi, where I am kind of working now. And thank you so much for your attention, for who stayed there so long. And thank you so much, Dr. Bennett, for giving me a like to go through the slides, and it was very, very hectic. Thank you so much, sir.
Thank you so much for the presentation. I particularly enjoyed it so much. It gave us so many explanations and things that I didn't know until now. And thank you so much for all this. We actually have a question in the chat. I would just read it. If at age of 14, we're fusing long level will cause restriction on growth, how do you decide at what age and how much to fuse?
Yes, this is the question we are always discussing with the patients. Generally, I personally, if they are 14, if the carb, I try to see how much is the carb. If the carb is like 35 until 40, I try not to operate. My in my dictionary, surgery is always the last, right? So if it is 14, most of we do a spine X-ray, we do the hip X-ray. There are something called a RISER grade, RISSER. So there you can see that how much is the maturity and whether they are going to grow more or not. So kind of calculation of the bone age. So you know that patient is going to grow at the age of 14. Probably the age wise they will grow, the X-ray wise they are going to grow. So then they are 35. So if they are 35, you don't want to do surgery. You send them to your scoliosis specialist, physical therapist. That itself is a very huge topic, the physical therapy and the bracing and what kind of physical therapy. So you need a physical therapist also in your team before and after surgery. So I will not do surgery. I will send them to our physical therapist. They will prepare the brace, and we will brace the patient because the patient is 14. At least until 15, maybe they will get some benefit. It may stop the progression, but at the same time, I will do that X-ray every 6 months and then see where we go. If the patient is say already 60° or having a neuromuscular scoliosis, then you know this patient is already 60°, already having so much difficulty in standing and so much pain. And not only pain, and these patients, when they go to school, they feel, they feel bad about their body, especially at this age group. The friends are asking, relatives are asking, so that part they are going through a mental trauma, and the carb is already 60. Then you don't really wait. So like, if you remember my first slide, that is a 15-year-old girl and whose carb has got worse over 2 3 years, or the boy who's 17-year-old, carb has become very worse from 12 to 17. Then you don't want to wait, you go for surgery. Okay, so as you can imagine, in the APX-ray they were pretty carved, so when you do the surgery they actually gain 2 to 3 centimeter inch weight, like inch height, right? So kind of 3 centimeter height. So they get very happy about that when they become 3 centimeter taller. And most of the patients, because they were in severe pain, and when they are kind of straight, it gives them a very good boost. They go to gym, they participate in activities, and they become much better. So the growth really, yes, growth is kind of restricted, but at the same time you are getting a 3 centimeter increase of height. And after the surgery there is a general belief whether I am not able to participate in any activities. That's not really true. Many of my patients, within a year, they are in yoga, doing Pilates, and everything you can imagine. Like, we tell generally to wait for 3 weeks. Many patients, they don't even wait. They don't tell us. They just start their activity because they're so happy.
Okay, thank
Any
you
more?
so much.
Yeah.
So the lives of the patients are improved, not just medically speaking, but also socially. And
Yes, that's
there
very
are many
important. Exactly.
levels of
Yes.
improvement, and that's, I think that's wonderful.
Yes.
Okay, we also have another question, I think.
Sure.
How long the segment to fuse can it be?
How long the segment?
Yes, the segment to fuse. How
Yes.
long can it be?
That's actually depends on, as I said, if they're a fresh patient, like means, first time coming to your office, you see their shoulder and how their scapula are, how their lumbar region are. And their x-ray, you know what is the upper level, what is the lower level. But then sometime I had a patient, that is, I will say, but she's a strong girl. See, I kind of see her Insta profile. She is so active, it's unbelievably active. But she's very tall. She has Ehlers-Danlos syndrome. So these syndromes are very difficult, because their joint laxity, they first develop a shoulder dislocation, then they develop the scoliosis. And by the time they came to us, she already had more than 6 7 surgeries in the spine. And if you combine scapula and spine, she already probably 15 to 20 surgeries. And then we see that screw has broke. As I said, that there can be adjacent sepal problem and the pseudoarthrosis not fused. So it was very challenging. We actually had to fuse, believe it or not, the whole spine. And I don't know, means that was so crazy to be, when I was in training. So it was very, very like, being a neurosurgeon, I was not really trained like orthopedic surgeon who put more screws. But for an orthopedic surgeon, also putting screw from top to bottom is pretty rare. But I was pretty skeptical about what is happening and what my boss is doing, to be honest. But to my surprise, she did very good. She had some issues. I saw she had some screw coming out, and she had to go for another surgery in last 3 years. But even now, I just saw her last, because she is very social media was active, and she is kind of a support group. She has several support group where she mentors the patient, what she is going through, and she tries to help. So everybody knows her, and she's doing pretty good actually, despite her spine is completely screwed from top to bottom. Only problem, she is like, she's super tall, it's very difficult to get into a car or coming out of car. So they have, because of the fusion, the mobility has completely gone when the whole spine, but otherwise she's doing decent. She's still walking without support, and she has a dog. I can see her, and she kept on posting, so it's pretty cool to see. So that is the highest I have done or seen. And the lowest is, of course, where there is no screw. You just treat the fractional carbon. Patient is doing for like 5 years, 6 years, they're doing good, no screws.
Okay, so that was the most severe case that you ever had,
Yes,
or
that was the most severe case I ever had. And then I had a patient who was like, I had two patients, extremes of age group. One was age 1 and one was age 90. So both were, you can imagine, both were super challenging to put the screws. So those are the two extreme patients, which was I will say, I of course I would not have been like, it was my boss's case. That's why I keep my boss's picture in my all slides. Without him, I will be never be even imagining to do this kind of, attempt this kind of surgeries. Yes, he was the one.
Yeah, I have a question. It's more of a comment. I'm not a neurosurgeon, but obviously you have to follow up with patients. Is using a video chat sufficient when you want to follow up a patient? I know it's hard for some patients to get to see you. Do you ever
We
use video chat, like to kind of check on the progress of patients?
In the time of COVID, we had to, right, all of us had to go for video chat now, right? So now worldwide we are doing so much of video chat. Especially I before and after surgery, I like at least one visit before and one visit after. And then I leave that in the patients. If they have minor issues, I always try to address on the videos. And but if there is anything which I'm not really happy, then of course I bring them back. If I have to examine the patient, I bring them back. But if they want to show me something or some part of the wound, I tell them to, in a, not of course in the WhatsApp or anything, in the saved in a protected media, to send them photos in our patient chat and videos. Yeah, I do a lot of videos, because many of these old patients, they don't really want to come, right? So, or the young kids don't really want to come, the parents. Or so if they have no like some questions, many a times we do that, they want to show one part of the wound, whether it is normal or not, then we kind of do many video chats. Yes. And I want to see their walking also, right? So that is also important, how they're walking. So that part video
Okay,
chat helps.
thank you.
Thank you, sir.
okay, if there are any more questions, please just write them in the chat or unmute yourself. If not, I have just one last curiosity. What was the longest surgery that you performed? Like,
Oh yes, this was actually, as I told you before, I did one presentation of DBS with Dr. Bennett before. So I came from like a neurosurgical background. So these surgeries are mostly not done by neurosurgeons, right? In 10 years back also, neurosurgeons were not really doing this kind of long surgeries. So orthopedic surgeons are the one who were doing it. But I will say, I mean, with respect to everyone, many times, as I showed some cases like intramedullary tumor or syrinx or a tethered cord or a CV junction anomaly, they kind of missed it, and it became more complex after that surgery. So then neurosurgeons started stepping into this, and it was very, very challenging in my fellowship. The longest surgery was, I did surgery, then patient developed during surgery intra-op monitoring. It showed like it is dropping, so we had to stop the surgery, take the patient to MRI, come back and do the surgery. So that became like almost like, I will say, 18-20 hours of surgery, because we had to stop, go down, MRI, come back, talk to the patient, and come back and do the surgery. So generally, adolescent ones can be done by 2 p.m. or 3 p.m. We will be probably done. But if you are doing a adult scoli, that will take 12 hours, even in the best hands. I know it's like, yeah, if you're super fast also, maybe, yeah, 10 hours, but 12 hours average. Yeah. So that makes you, that's a complete different kind of, generally young surgeons are doing that. You, when you become old, you don't really want to do these surgeries. So, and I will say, in my current here, in my current workplace, so three surgeons are interested in scoliosis. So all three, actually we scrub together, to be honest. So we kind of take part. So two surgeons start, then one go take a little bit rest, have food, come back. So all three know what will be the next stage. So we don't really have to tell anyone that what is the next stage. And then one person goes in out. So that's how we are doing it here. And I'm pretty happy with that practice, because everybody is keeping their skills at the same time. We are not really tired, and so that needs a team approach. So I will always recommend to do at least two surgeons. Three is a luxury, but two surgeons I will always recommend. In my previous workplace, there was always two surgeons to do this kind of surgeries.
Okay, so it can be a multidisciplinary team,
Yes.
and
Yes.
everyone.
Actually, to be honest, believe
Yeah.
me, if it is best, if it's a orthopedic surgeon and neurosurgeon doing both together,
Yeah.
that makes the best team, because we are a little bit more careful when we are going close to the nerve, and they probably, by their experience, they know whether the screw is right at the position, and when we are rotating the rod to correct the carb. So kind of that part. So yes, both have to know both part, but a combination of neurosurgeon and orthopedic surgeon probably is the best team.
Yeah, and everyone just brings their experience on the table, and that's the
Yes,
perfect
exactly.
combination. Yeah.
Their experience on the table. Yes.
Yeah, that's perfect.
Yeah, I have a
Okay.
quick question.
Yeah.
Now you've trained in a couple of cultures in the
Yes.
Middle East and America. Do you see much of a difference in standard of care in scoliosis between those two cultures?
100%. That's very important questions, and that was my challenge in the beginning, right? So, say for example, from starting from the diagnosis itself, right? So in United States, most of the schools, they have a when they do the annual checkup, they do a scoliosis check also, right? They do your eye test, but they do scoliosis check also. At least in Arizona, it was, many of the schools were doing that. So they get detected early, and they come to your office early. When you give them options, it's much easier. But in Middle East, it becomes slightly difficult, because their dress is different. Many a times they're covered, and so they are not really getting detected in the beginning. And then you tell about these big surgeries, maybe a few years it will change, but you tell big surgeries, everybody gets scared. In United States, like, everybody knows now that this surgery happens, what is the safety rate, what is the complication rate. So most of the time patients are coming to your office, they know a lot, and they are, after surgery, they are making, say, tattoos in the incision, they are going out, they are not really, means, not really shy, or embarrassed that they had a big cut in their back, and
Mhm.
that part. But those things, the cultural things, are pretty different here, and many a times it happens in the families. So United States, again, it is easier, but in Middle East it's not really easy, so because of the cultural difference.
Thank you.
And in India, I did some, in India it becomes a different aspect is, this needs a lot of screws, right? So I didn't show one slide. Of course, I cannot do like this many screws in India, where patient will not come to you. If this much is needed, they will not be able to afford that. So affordability becomes another issue. So we skip level. So that particular itself is a topic, which level to skip and which level to put screws. And we try to put minimum screws, and to attain the like maximum carb correction. So that becomes a whole different challenge, that which so in United States is much of a luxury. You can put, like, you try to put all screws, and give the best correction, make it completely straight. Even if question comes at 70 degrees, 75-degree, you can practically make it zero. But in India, I have to do something different. So that is another challenge answering your question.
Okay, Madalena, I think we can wrap it up. You want to wrap it up? A few
Yeah.
words of wisdom?
I think it's okay if there are any more questions. Thank you so much for this meeting and this presentation, because I really liked it. I liked the talking and everything about this meeting. Again, I am so sorry for
No, I am sorry. My surgery went so long and I wanted to go to home and do it. I know hospital sometimes this becomes an issue. Half the things they kind of block it. And so
Yeah.
sorry about
Yeah.
that. So that
It's
becomes you cannot upload it. You cannot open your Gmail. That becomes a big problem.
yeah,
Okay.
it's
Okay.
perfectly
At
fine.
any rate, I'd like to thank everyone for the patience, including Dr. Chan Moy.
Thank you so much.
It's like neurosurgery, Dr. Shi. Sometimes things don't go the way you want to go.
Yes.
It's the same with computers.
That's
Exactly,
so true.
sir.
Okay, thank you.
Yeah.
Thank you,
Bye-bye,
sir. Thank you,
everybody.
Thank you,
everyone.
everyone.
Thanks.
Bye bye.
Bye.